Hello, welcome to the CIRS Healing Collective expert guest video series. I'm Jenny Johnson, the host and facilitator of the CIRS Healing Collective, which has been a resource for aspiring CIRS overcomers to share and connect from around the world since 2020. I'm a Shoemaker proficiency partner and CIRS coach, and most importantly, an overcomer myself. What you're about to see is a 10-minute excerpt from a 90-minute group discussion that members of the CIRS Healing Collective got to have live with this expert guest. If you would like to see the full 90-minute replay, come on over to the CIRS Healing Collective. We have a robust video library from the past 5 or 6 years of so many expert guests. Better yet, you'll be able to join our future monthly live discussions with experts to come. We'd love to have you.
Gradually migrated out of pain practice and in that particular form because I felt like it was not addressing the root cause. I wanted to be able to reverse conditions. And I mean, the ultimate goal is to cure. So quite by chance, one day, I encountered a patient who looked like she had some sort of neurological condition. When I shook her hand, she just started shaking and looking like she was having a small seizure. When I asked her about if she had Parkinson's disease or some other neurological condition, she said, "No, I've been told that I'm crazy by 2 neurologists." And I said, "Well, okay, just tell me, you don't have really pain, but just tell me how this started." And so she related to me that about 10 years prior, she had lived in an apartment that developed mold. And then she developed asthma for the first time in her life in her 50s. Her asthma progressively worsened to the point where she was put on high-dose steroids. And soon after starting the high-dose steroids, she developed all of these tics and neurological conditions. And so I said to her, "Well, why don't you see a neurologist? I'm not quite familiar with anything that mold does to people." And she said to me, "No, please, if you send me to someone else, they're just going to tell me I'm crazy." And she seemed very sane, very rational, very composed despite her medical condition. And I said, "Okay, I'll read a book about this, and why don't you see me in a month? I can't commit to treat you or help you, but if I find anything, we can at least discuss it." And I went on Amazon and I looked for a book, by a doctor that looked, reputable. And I found a book called Mold Warriors by Dr. Shoemaker. And as I read the book, I remember it was actually an iPad. It was like, yeah, I think I got to not the iPad, the Kindle version. I was reading it on my iPad one weekend. And the insights were astounding. The fact that, hey, there's this epidemic of people sickened by buildings, by the fact that you could measure these different markers objectively using LabCorp, Quest, and other groups. The fact that you could use this visual contrast test and start evaluating at the point of care whether patients were showing this deficit that I had never heard about. The patient came back and I told her about the condition and I started her on a binder. And unfortunately, in her case, the binder didn't particularly help. But soon after, I saw a second patient who was a young man in his 40s, muscular guy who was coming to see me for back pain. But as sort of a throwaway comment, he said, "Doc, someone told me I have fibromyalgia. What is that?" And I said, well, fibromyalgia is a diagnosis where the cause is not known, but the person has pain, depression, other symptoms that are not accounted for by any other medical condition. And then I told him I'd recently encountered the idea that fibromyalgia is often a manifestation of damp building exposure. So this gentleman worked in a car dealership nearby. And he said, and then when we looked at the history, his symptoms had started at the same time he got promoted and started work in a new office. He said every morning he had to wipe off a layer of white mold on his desk. And he described a broad range of symptoms, that so-called multi-system presentation that Dr. Shoemaker had described. In his case, I wrote him a letter to avoid his work. We started him on medication, and he was my first patient to have a successful outcome from treatment. And from there, I started my private clinic shortly afterward, and then I've been able to treat both CIRS patients and spine patients. And when I look back, I think it's ironic because when I was in the pain clinic, the two groups of patients that I struggled the most to help, and that I, for that reason, dreaded seeing, were patients who had fibromyalgia, chronic fatigue, and patients who had low back pain. Those were the patients who tended to be, once you got them in a chronic pain clinic, they were your patients for life. They're every month for their medication. A person can feel pain because something is happening to their tissues, or because they think something is happening to their tissues. Or they might be, people can sometimes have psychosomatic and imagined pain. That idea is very central to where pain medicine is at the present date. And I would say where pain medicine is, for the most part, is often contradictory and lost. So the two extremes of chronic pain approach is there are programs that will say that if you've had your pain for beyond a certain amount of time for a given condition, then it's in your head. So they're saying that the physical sensations you're feeling is a manifestation of kind of crossed wires, if you will. So then, and then the other kind of extreme, which is increasing, which is less popular now, but which was the original viewpoint, is pain as a reflection of underlying tissue damage. So if I step on a tack, it's going to pierce my skin, and the nerve endings are going to send that signal to my spinal cord and up to my brain, and that's going to register as pain. So I think that what's missing in pain medicine nowadays is the ability to precisely diagnose the underlying cause. And I would say the first mental map I would apply is to think whether, I think that there's one mental map is, well, is the pain physical, or is it more of a mental sort of pain? Because psychological pain is also a form of pain and kind of counts. But let's just stay in a category of pain that appears to be physical. The next branch point I think about is whether the pain is from more of what I call a mechanical source or a metabolic source. So let's do some examples. So a mechanical source of pain, I step on a tack. I have a disc bulge in my back that's pushing on a nerve. I have bad knee arthritis. On the metabolic side of the pain, you can think about inflammatory conditions, the rheumatoid arthritis that's eating up a joint, the muscle soreness from somebody who has a myositis or muscle inflammation. So I try to think about, ultimately the pain is occurring at a tissue, but was there some sort of physical injury, or was there something more of a metabolic injury involved? Mm-hmm. And then, so in the case of my spine patients, it's almost always a physical origin. When you look at CIRS pain, it's often guided by system-wide inflammation. And then the pain presentations I see in CIRS, it runs the entire gamut. For many CIRS patients, pain is not a part of their presentation. For other patients, pain is the dominant part of their presentation. And when you look at, one clue is, when you look at that CIRS patients with pain, is there's really two or three main possibilities. One is they have a physical injury of some kind, and then because they also have CIRS, they attribute it to CIRS. Another is the system-wide inflammation is causing a condition from the CIRS. And the third possibility is they have another medical condition that is also inflammatory, but is not CIRS. And I think that because CIRS can cause such a broad range of nonspecific symptoms, I think the biggest mistake I see clinicians in the community make is to presume that the pain is from CIRS automatically, without, it often is, but without evaluating it, it's presumptive. When I see the overlooked conditions that we see in our CIRS patients, I'll go through a few of them. One is called erythromelalgia. Erythromelalgia tends to be a red burning pain that people experience in their hands, their feet, ears, or nose. Erythromelalgia is something you can see oftentimes because the affected part of the body will turn red and feel intensely hot and will swell up during those attacks. That pain is characterized by a reduction of pain when the limb is elevated. So if the hand is elevated, or in the case of the foot, the leg is elevated. And it tends to be episodic, often is triggered by